This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
Hi there, I'm Professor Michael Chapman. I'm a fertility specialist with the Life Fertility in Sydney, and I have been devoted all of my life to educating doctors, educating patients about what fertility is about and ways to help people get what they want, i.e. a baby. As part of that, I've been doing these podcasts now for 3 or 4 years, and indeed, this is the 500th episode. 500 10-minute slots of my time, in the hope that I can help couples, individuals, women get through the problems that the infertility journey, the IVF journey, creates. During that time, the world has moved on in terms of success rates. I mean, in that time frame, some recent Australian data showed a 10 to 15% rise in the take-home baby rate from a cycle. And why is that happening? It's not because of me. It's because the laboratories are getting better and better and better, that we're mimicking nature more and more, and we're able to select out embryos that are better and better as a first-up option, and therefore bring pregnancies sooner rather than later. So over the 500 episodes, I've covered, I think, virtually every topic that fertility throws up, from the ethics to the male, to the female, to the polycystic ovaries, to the cycle processes of IVF, to the psychological impact that infertility has. All are vital subjects, and I hope over that time, over those episodes, those that have reached out to listen to them, and my statistics suggest that it's over 300,000 downloads of these podcasts have occurred over that time, which is amazing. Across Australia, over 60% of our readers or listeners are from Australia. But that means that there's a pile from the rest of the world, from the United States, United Kingdom. I've had emails from patients in Sweden on their journeys and using my podcast as a reference source to help them through their time. So I think it's been a useful exercise. And probably what it does say is that I can talk. But my talks are based upon the 40 years of expertise. It's 40 years of working with people, women, to get them pregnant. So tonight, I thought I'd talk about polycystic ovarian syndrome. And I know I've talked about this before, but it is a very common condition. Women in general, if we use the ultrasound diagnosis of multiple follicles in the ovary, even if you don't have symptoms, accounts for 20% of women. 20% of women have this polycystic looking ovary. That doesn't mean that you're going to have problems with infertility. It doesn't mean that you're going to have irregular periods. It doesn't mean that you're going to have excessive hair growth. It's only 5% or less than a quarter of those women with the ovaries on ultrasound actually develop symptoms. With that 5%, in fact, the easiest from my perspective to treat, that's been my experience, that I probably have more pregnancies without IVF, in particular, with women with polycystic ovarian syndrome. So syndrome, rather than ovaries, is the collection of symptoms and signs that include the ultrasound picture of multiple follicles in the ovary, but it also includes irregularity of cycles due to lack of ovulation and the other symptoms of increased pimples, increased hair growth. And they are the characteristics of classic polycystic ovarian syndrome. Usually it's in women who are slightly overweight, but it can occur in very slim ladies as well. In fact, polycystic ovarian syndrome in slim ladies is quite a tricky process to deal with, because these ovaries in those women are incredibly sensitive, and you need to be treated by somebody who understands what's going on. So polycystic ovaries, why do we get polycystic ovary syndrome? Well, the truth is we don't know. What we do know is that when we measure the various hormones, there is an imbalance. What goes on is that the follicles in the ovary produce estrogen, which is what's normal, but because they don't reach maturity and ovulate normally, that estrogen level is pretty constant at a middle to high range of estrogen within the normal range. They're not excessive estrogen, but they're in that normal range. But what doesn't happen is it doesn't go up and down. The stimulus for the pituitary gland, which controls ovulation, controls the hormone that stimulates ovulation, the control room in the pituitary is looking for changes in estrogen. As estrogen goes down, a hormone called follicular stimulating hormone, FSH, rises. And as its name says, it stimulates follicles, stimulates egg growth. So if there's not a fall in estrogen, there's not going to be a rise in FSH, and therefore not a stimulation to produce a follicle that will produce an egg. So that's where the pathology is. But what actually starts that process, no one really knows. There are some theories. I've done a bit of work in the past looking at stress levels in women. And clearly women who around the time of puberty were under significant stress. Parents divorcing, exam stress, I think life events causing stress. Those girls were more prone to end up with polycystic ovarian syndrome. And so there is some suggestion that the adrenal gland and the hormones from there might play a part in the origination of the polycystic problem. So polycystic ovarian syndrome, relatively common. When I have a patient come through the door and I sit down and we talk about her irregular periods, almost always it's going to be polycystic ovarian syndrome. And I almost have a smile on my face because I know I've got a 90% chance of creating a pregnancy for that person within the next 12 months. The treatment that I'm alluding to is to stimulate or to give medications that make the pituitary realize that think that estrogen levels are falling. So going back to what I was saying before, if the pituitary gland, which produces the FSH, thinks that estrogen levels are falling, then it will stimulate ovulation. So there are two drugs that have been used for many, many years now that do that job. Clomiphene was the original one. Clomiphene was the original drug that we used. It goes back now 50 years. And it's what it is an estrogen receptor inhibitor. In other words, it attaches itself to the pituitary gland where estrogen normally is entering the cell. And the cell internally thinks, oh, there's no more estrogen coming in. It's time for me to produce FSH. So that blockage of estrogen getting into the cell is what clomiphene does highly successfully in inducing ovulation in women with polycystic ovarian syndrome. The more recent drug, and while it's recent, we're talking about a decade, is letrozole, Femara, which has been used for 30 years in treating breast cancer because it blocks estrogen receptors, and it also changes estrogen production. So it blocks, it's called an aromatase inhibitor. It blocks the conversion of androgens to estrogen. So once again, you get lowered estrogen levels, and with those lowered estrogen levels, the pituitary gland thinks, oh, let's go for the FSH, let's stimulate a follicle and get ovulation. Both these drugs have minimal side effects. We tend to use letrozole more commonly because the multiple pregnancy rate is lower. If you take clomiphene and you've got polycystic ovarian syndrome, and we get you to ovulate, there's probably somewhere between a 4 and 8% chance you'll end up with a twin pregnancy. Not what everybody wants. Whereas with the letrozole, we're down around the 2% mark. Side effects, I said they were minimal. Clomiphene is the one that has slightly more side effects, and some women feel a bit nauseous. Some women get flashing lights in their eyes, although that's usually only at higher dose. The problem for many women in today's society with polycystic ovarian syndrome is they want a baby yesterday. All I'm doing by giving you those medications is putting you back to normal rates of fertility. And normal rates of fertility in a woman under the age of 35 is 15 to 20% per month. Now, if you've been having irregular periods and you've been trying to get pregnant for a long time, 15% to 20% is not much, but it's every month. And every month that you do it, you're increasing ultimately the chances of a pregnancy. I always use the analogy, 15% is actually 1 in 6. So it's just like a dice. You pick up the dice and you roll it. The good news for the PCO women is that that dice is now 1 in 6 and not nothing when you don't ovulate. Now, that means there has to be some patience. The statistics with clomiphene and with letrozole is that after 6 months of treatment, there's a 60 to 70% chance of a pregnancy without doing any more than taking 5 tablets a month and having intercourse at the right time. Obviously, assuming the boy's sperm is good and good value and you've got open fallopian tubes. But treatment is good. Treatment is very successful. If that doesn't succeed, or there's another factor like male or different problems with the tubes, obviously we'll move on to IVF sooner rather than later. And ultimately, that is a direction we might need to take. But it's down the track. And I encourage people with polycystic ovarian syndrome not to be talked into going into IVF straight away. Nature will do most of it for you if you just take these tablets on a monthly basis. So PCOS, interesting sequelae. I mean, the follow-up is interesting in the sense that the women with PCOS, particularly if they're overweight, are more likely to get diabetes in pregnancy and, in fact, diabetes in later life. They're also more likely to get higher blood pressure in pregnancy and, again, in later life, whether that's obesity itself or whether it's just the condition of PCOS, we're not sure. But in any case, we have to think about those things, but that's going forward. And the general message in the long-term health of women with polycystic ovarian syndrome is to keep your weight down because that normalizes the hormones and no end.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.